these lymphocytes and all these lymphoid cells to try to help the child fight off every infection that he's never been exposed to, right? So when you're a kid, that's why kids get every cold and every little bug that comes through, because they've never been exposed to them before. They're not immune to anything, and their thymus is working overtime to try to help them catch up and become immune. One thing that's kind of interesting is that the right arm over here, it has a series of lymphatics, and it's the only group that does not meet up and dump in here at the thoracic duct. It kind of dumps in on its own side over here, along with the right side of the head and face up there. We'll show you better pictures in a second. So what is the function of the lymphatic system? Well, in one word, in one sentence here, it's really to produce, to maintain, and to distribute lymphocytes, because lymphocytes are those magic bullets that are going to enable you to fight things very specifically. Where do they get made? Well, they get made in everywhere you might even think about them being made, in all the lymphoid tissue. In other words, all those things that were just on that little picture, like the tonsils, and in the lymphoid organs, the spleen, the thymus, and they're also made in the red bone marrow where all the other cells are made. Where are they found? Well, they're found in your bloodstream, because you guys looked at blood smears and you saw lymphocytes, but they're also contained out in the tissues. They can go out, like if you have a thump on your hand and have a little infection starting in your hand, then the white cells, including the lymphocytes, will go to that area. They just go right out through the walls of the capillaries and try to do their job out there to fight off that infection, whatever it might be. So they would go from the blood into the interstitial fluid quite easily. They can also return back into the venous blood. And lymph, by definition, is that extra fluid that's interstitial fluid. So it's not from in the cells, it's from outside of the cells, and it is entered a lymphatic. The fluid in the blood and in the lymph, they go back and forth, and they transport hormones, nutrients, and all kinds of stuff. So lymph doesn't just function to remove water from your body, it also functions to remove these other things as well. These lymphatic vessels are super tiny. Like I said, I did 10,000 operations, and I'm not sure I ever really saw a lymphatic vessel at all, except for those lacteals that were full of white fat. The thing that's different about lymphatics, they're very different than capillaries. First of all, they're very, very small. It's not a system, so there's not arteries going out and veins coming back. It's a one-way stream. So at the distal end, you have just open pockets that collect the fluid, and then it goes one way up to the thoracic duct and up back into the venous system. Sometimes they have larger diameters than the smallest capillaries, but they're very thin-walled and they're very irregular, and you just, like I said, they're so small you don't see them. This is a little schematic that I think has some relativity. Here's the blood vessel systems that we've been studying, and you've got arterioles that bring blood out, and then you've got these controlling ones, and then you've got capillary beds, and then the blood is picked back up and carried back up by the veins. On the other hand, the lymph system, which are these tiny little vessels, and they don't show up very well because the fluid that's in them is clear. That's one of the reasons they don't show up. They're lined by endothelial cells, same as the capillaries, but they're one way. So they just collect the fluid. The fluid gets out of the interstitial fluid out in here, gets into the lymphatics, and it goes upstream. And it's a one-way trip. It's not a two-way trip. Another close-up view of just quite a lot of pores in the side that allow the lymph to get in. Here's a lymphocyte. There's another lymphocyte up there. Here's a capillary out here with blood in it. These don't have blood in them. They just have water, which is basically called lymph. They go from smaller to larger. I've talked about lacteals already, saying those are the ones you can see. Here's a nice picture. I don't know how they got this picture. It's a microscopic picture of a lymphatic vessel, and it flows in this direction. And these are tiny little valves in it. They're the material cells that make up these valves is much thinner than toilet paper. And that's why they can be damaged from time to time. But it's a one-way deal. So the lymph flows this way, but then it can't flow back. That's the idea. The biggest duct in the whole system that we've already talked about is called the thoracic duct. And it collects, it takes the lymph that collected here in the cisterna chyli, that cistern in the upper abdomen, and carries it up and dumps it back into the junction on the left side over here. This is kind of a weird thing. I don't know why it got designed this way, but both legs and the whole abdomen drain into that cisterna chyli right about here. The drainage from this side of the head comes down this way. The drainage from this arm comes down in this way. And all three of these meet up and join the thoracic duct and then enter into the junction over there on the left side of the carotid and the brachial vein. The right side is different, as I mentioned earlier. The right arm, the right side of the chest, and the right side of the head all join into the right lymphatic duct, which is really super tiny compared to this one, and empty into the venous system on that side. You can actually see the thoracic duct. It's just that we're hardly ever back there to see it. This is it, this kind of greenish tube. They've made it green. It's not really green, it's clear. Here's the cisterna chyli, where all the lower extremity and the abdominal lymphatics all meet up here. And then they head up through the thoracic duct, take this little loop and jump in right there at that junction of the jugular and the subclavian vein. The right side, which involves a lot less, also has a little duct. It dumps in on that side. I can tell you a story about the thoracic duct. I can say that in my career I only saw one thoracic duct. And it was a young guy who had been injured. And I don't remember what the injury was, but somehow or another his thoracic duct had been torn. Now, we didn't really know that, because what he came in with was his chest full of water. And so it's called a hydrothorax, chest full of water, as opposed to a pneumothorax, which is chest full of air, right? And we would put a tube in, and we would suck all the fluid out, and then we would do some analysis on the fluid, and we come to find out that this was lymph. It wasn't just serous fluid or anything like that. It was truly lymph. And the treatment for that normally is you just put a tube in there, and then you just keep sucking the fluid out, and eventually the little hole or tear in the thoracic duct will close off, and the fluid will find other ways to get out. Well, we sucked on this guy's chest tube for like a month and a half, it seemed like. He was in the hospital. He was getting sick of us. And we finally decided to operate on him and go in there and try to find the hole. And the other thing we did was we had the radiologists, they can do what's called a lymphangiogram. So they can go down on the top of the foot and make a little incision and find one of those tiny, tiny little lymphatics with microscope glasses and all that stuff. Put a tiny little catheter in there and squirt some dye into the lymphatics, and it fills up the cisterna chyli, fills this up, and then it was leaking out of a hole right about there. And so we knew about what we were looking for, and we did a thoracotomy, went into the chest, pushed the lung out of the way, and were able to find the thoracic duct and tie it off, both above and below. That solved his problem. He was a young guy, and he did not develop a bunch of edema, because the thing you worry about is that if they don't have a way for that fluid to get out of their legs might swell. He was a young guy, and he developed plenty of other channels to get it out of there, and he did fine. That's really the only time I ever saw a thoracic duct.
So you can't patch them or stitch them or anything, they're too thin?
No, they're just too tiny. Good question, though. Here's a autopsy picture of it. This is the aorta right here next to it. Here's the thoracic duct, this thing shown in yellow. I assume that's it. Yeah. Lymphedema is what happens if you don't have these things working and you get swelling in your extremities. I think I had some, well, I have some pictures coming up. Lymphedema can be massive. You've seen probably people in your life walking around the hospital or in a wheelchair that have just massively swollen legs. Well, that's usually caused by lymphedema. Now, that can be caused by a number of reasons. They could have gotten an infection in their lymph system that just destroyed all their lymph ducts. Whenever they get it, though, it causes very severe swelling, and when you have that much swelling, your body can't fight infection very well. There's just too much water everywhere. So they tend to get lots of infections in their legs and skin and so forth. We talked about lymphocytes a little bit when we were talking about white cells back there, and we said that about 20 to 30% of your circulating white blood cells are lymphocytes. But you just need to know that that has no bearing on really how many lymphocytes you have, because most of your lymphocytes are not circulating around in your blood. Most of them are sitting in your spleen, in your tonsils, in your malt, in all these lymph nodes that are around your body. That's where most all of your lymph nodes, where most all of your lymphocytes are sitting. There's three basic classes of lymphocytes that you should be aware of. T cells, B cells, and NK cells. I already mentioned NK cells. They're the natural killer cells that kill off any cell that doesn't look normal. T cells, the way they got their name is because they came from the thymus back when you were a kid. Their originators came from back there. They're called thymus dependent. And then the B cells, the only thing that makes them B cells is the fact that they were originally formed in the bone marrow. Now, if anybody has a friend who has AIDS, or if you have AIDS, and believe me, I've had a lot of students in my classes here that have AIDS. Some of them tell me and some of them don't. That's okay. The T cell count is the most important thing in the life of an AIDS patient. If you don't have enough T cells, you can't fight infection. And those are the folks that die of AIDS, because some little infection, some infection that wouldn't slow you or me down in the slightest bit, will kill off an AIDS patient if they don't have T cells to fight it off. So if the AIDS patients these days, they go in to see the doctor, and I have to tell you, it blew me away, because I was around during the beginning of the AIDS crisis where you weren't even allowed to tell people they had AIDS because they didn't want to know, because there was nothing you could do for it. And you were just, it's like saying, I just want to tell you you've got AIDS and you're going to die, and there's nothing we can do for you. So people fought, and in fact all the gay groups and everybody that had a lot of AIDS, they all fought routine testing, they fought routine notification, they fought everything, because there was nothing to offer. Once we got drugs that could treat AIDS, then it all changed, and then everybody wanted to get tested. Do I have AIDS? Because if I do, I want to be on medicine, right? Perfectly typical response, I think. But it was very interesting because I lived on both sides of that curve. It was so amazing to have patients who, you're trying to figure out what was wrong with them and you couldn't figure it out. And you'd say, well, we have this test called the HIV test that we could order on you to see if you have AIDS. And every one of them would say, no way. If that's what I got, I'm going to die. Why do I need to know? And that's the way it worked. That lasted for about 4 or 5 years, I think, until the first antivirals became available.
Did they know at the time how it was spread specifically?
No.
Oh, okay.
At first, we didn't even know how it was spread. Yeah.
So they wouldn't know that they were then going to spread it to other people, they just thought it was their own.
And they didn't care. They really didn't care because they felt like the whole system had let them down. There was no treatment for it. They didn't know where it came from. Nobody knew where it came from. It was a weird time in American medicine. It was the one epidemic that I felt like, even although I was a surgeon and didn't deal with these kind of patients much, it was odd. It was very difficult. I gave a patient AIDS once. I had a patient come in who was an older guy. He came in and had a ruptured abdominal aortic aneurysm. We saved him, gave him, I think he got 10 units of blood in his resuscitation and bleeding from his aneurysm. And he lived about 5 more years. And then I saw his name in the hall at the hospital, and he was under the treatment of one of the internists. And I said, what's Woody doing in the hospital again? I did an aneurysm on him a few years ago. He says, oh yeah? He says, did you give him any blood? I said, yeah, I think he got a bunch of units of blood. And by that time, the HIV test was available. Remember, there was a number of years there when a lot of people got AIDS, including Arthur Ashe, the great tennis player, got it from he had an open heart surgery and got 2 or 3 units of blood, and one of them was HIV infected. He died of AIDS from that. A lot of people did. And I said, what's Woody doing in the hospital? He says, well, he's lost a lot of weight, and he's got diarrhea, and I'm thinking he may be the first ever case of AIDS in the Dalles, Oregon. And he says, I got to talk to him and his wife about getting an HIV test, because you had to go through this incredible protocol to even draw the blood for an HIV test, because nobody wanted to know. And they had to sign away saying, I realize I'm getting tested for something that has no cure, and then if it's positive, I'm going to be told it's a fatal disease that has no cure, and all this kind of stuff. Well, anyway, Woody had AIDS. He had gotten it from one of the units of blood that we gave him to save his life from ruptured aneurysm. He'd gotten 5 or 6 years out of it, but he died of AIDS from blood that I gave him. So there you go. Anyway, so the T cell count is very, very important. When an AIDS patient has a low T cell count, the doctor is going to change their medicine. They're going to change the combination of the antiviral drugs they're on in order to try to come up with a combination of drugs that will allow their T cells to increase so that they can then fight off infections in a normal manner. I had a student a couple years ago here at PCC. Wonderful student. He told me the first term I had him, I think I had him all 3 terms, he told me that he had AIDS and that he had gotten AIDS from being gay. Sad thing was he'd gotten AIDS because he was gay, and then he got beat up one time because he was gay and mugged and stabbed and beat up and left to die down in Old Town when he was living on the street for a while, and he got a whole bunch of blood, and but he didn't. By that time we had an HIV test, and so he didn't get it from the blood. But he decided he wanted to become a healthcare worker. That's why he was taking A&P here, and I sat him down. I said, would you mind if I just talk to you one day up in my office? I'd like to talk to you about what it's like to have AIDS today in America. And he says, well, he says, I feel great every day. And he looks absolutely in perfect shape. He's a little bit buffed, but not total. But he looks healthy as a horse. He never missed a class. I said, how often do you see the doctor? He says, well, just every 6 months or a year now. I'm like, really? Because in the early days, they saw the doctor every week to get all these blood tests, because the drugs were so toxic at that time that if the disease didn't kill you, the drugs killed you. But now it's a lot better. He says, yeah, I just go in every 6 months, and he renews my pills, and I check my T cell level, and I check my viral load. They can actually count how many HIV viruses are in your blood, And he says, my viral load has been 0. I haven't had any virus detected in my blood now in 4 years or something like that. But he says, I do take the medicine every day religiously, and it works out okay. How much does it cost? $15,000 a year for his pills, which is why overseas, in most countries, there's just no help for people. You get AIDS, you're gonna die, because there is no Medicare, there is no Medicaid, there is no health insurance, there's nothing, and those people all just die very quickly of it. But he's doing great, and I think the day is coming, and I'd like to see it happen in my lifetime, that having AIDS is like having high blood pressure. Yeah, you got high blood pressure, and it's a dangerous disease, but you just take a pill every day, and even though we don't even know what caused it, you'll live a perfectly normal life. And I hope that day comes for AIDS as well, where, yeah, they have to take pills every day, but the price should come down, and hopefully they'll live a perfectly normal life. Yeah.
Didn't OSU find a cure?
There is no cure yet. There's one. I think they've had one patient that they call it a cure. It's it's being worked on. It's being worked on really, really hard, and I suspect it will change.
This is kind of off the topic, but I know someone who has cancer, and he's taking that new, it's like a trial thing where it actually fights the bad cells. Mm-hmm. And what it's doing now though is it's tearing his liver apart, because he once had problems with his liver, and now it's just completely deteriorating again too.
Well, I'll give you my little preaching about the FDA and the Federal Drug Administration and the process that in America we make drug companies go through before a drug gets it on the market. And he's probably in a trial. If a drug company is wanting to propose a new drug, they have to, show how they made it and how it's pure and all this kind of stuff. And then they have to do animal trials first. And then they have, if it still seems to do what it's supposed to do and it seems safe in the animals, then they'll do human trials. And of course, human trials are fraught with all kinds of lots more problems, because a lot of things are different about animals than humans, but a lot of drugs get weeded out at the animal level and never get it into patients who it would have probably killed. Like this one sounds like it's killing him. That's just part of the deal, and he signed up for it knowing full well that there was complications. And people are always bitching in this country, and they're saying, well, I don't care if I have complications from this drug. Give it to me anyway. FDA should approve it right now, because there's people like me that are out there dying from it, and we should speed up the drug process, the process of approving drugs. And what I always say when I hear that kind of talk is, do you remember thalidomide? And thalidomide, what's thalidomide? Well, thalidomide is a drug that was given to pregnant women for morning sickness back in the 60s. And it was given to millions and millions of women in Europe. It was never, ever approved in the United States. By the time they figured out there was a problem with it, there had already been hundreds of thousands of babies born with no arms or no legs, or little tiny short arms, maybe a hand right up here at their shoulder, things like that. The thalidomide babies, hit the news once they started saying, oh, wait a minute, my mom, oh yeah, mom took thalidomide when I was pregnant. And the women started figuring out, and I mean, hell, they took it for morning sickness. It wasn't like they were taking it for a death-defying disease. But the doctors and the drug companies were pushing it big time in Europe, but it was never approved here. And all that information came out. It was never, ever approved in the United States, ever. And so if you ever think that we take too long to approve drugs, just say, do you remember thalidomide? And I do. because it was in the early 60s and I was a teenager. And I remember the news reports. I had a couple of friends who had, no legs or one leg or one arm, and it was terrible. Interestingly, thalidomide is making a comeback. They're using it to fight cancer now, because what it does is it prevents arteries from growing. It has an anti-angiogenic effect. And so they're using it in tumors to cause the tumor not to grow any more blood vessels, and if it can't grow any more blood vessels, the tumor will die. So thalidomide is being used now in research on tumors, which is kind of interesting, because it came when it hit the market in the 60s. It was a really bad deal. These kids weren't growing any arteries to their arm, so therefore their arm wasn't growing, or leg. All right. So the T cells are the big ones, the big deal. They're the AIDS ones that are so important there. They make up about 80% of your circulating lymphocytes. There's three kinds: cytotoxic, helper T cells, and suppressor T cells. Just know that there's those three types. All the lymphocytes, you can't tell the difference by looking at them. They look the same. And just remember that lymphocytes wander out through your tissues. They go in and out of the blood vessels, out into the tissues. And this is a key point right here. Lymphocytes can live for years and years. Remember, blood cells only last for 4 months, but lymphocytes can last for years and years. Well, isn't that nice? Because if one of your lymphocytes or two of your lymphocytes in your whole body are specifically making antibodies to help you fight, how about typhoid fever? You'd like them to live around so that if you get exposed to typhoid fever 10 or 12 or 14 years from now, you'll still be immune to it, right? So it's nice that these lymphocytes do live for so long.
Question?
Yeah.
Do they clone or pass on that information to new lymphocytes, or
That's a good question.
Does it die out with the generation?
Most when it says years, a lot of that's the rest of your life. A lot of these things, especially a lot of the drugs that you've been immunized against, you do stay immune for the rest of your life. There's some immunizations that you have to take a booster 10 years later or 15 years later because you lose immunity. That would be a case where they don't live long enough, obviously. This is just kind of a summary of the blood cells and how blood cells are made. Remember that blood cells are made from hemocytoblasts, and that forms not only red cells but also all of the white cells. And here they are. Here's the important white cells, which are these lymphocytes. They're all made from the lymphoid stem cells over here that are made and make immunological surveillance. The NK cells, looking for abnormal cells, antibody-mediated immunity from B cells, and T cells, which also help with cell-mediated immunity. I'll just leave it at that. Here, yeah.
What's the reproduction rate of the white cells? Because if you go in and you have a fever or something, they check your white blood cells, and do those
goes up pretty quick.
Quicker than red blood cells then?
Oh yeah, in 3 days you can go from a total white cell count of normal 5,000 up to 25,000 if you have an infection. But remember, that's only the ones that are in your bloodstream. There's lots more that aren't in your bloodstream that are made to fight infection as well.
So are some of those that they count in the smear maybe were ones that were sitting idly and they got dumped in?
Got dumped into the system, yes. But it's still just as important from a number point of view. This is the tonsils. The pharyngeal tonsil is this guy up here. It's often called the adenoid. If you look on the surgery schedule every day, you'll see little Bobby Jones is getting a TNA, tonsillectomy and adenoidectomy, which means he's getting his palatine tonsils removed right here and his pharyngeal tonsil. Now this lingual tonsil is part of your tongue down here. That's usually not an issue to anybody, so they don't usually remove that one because it just doesn't need to be removed. as long as I'm telling malpractice stories, I'll tell you another one that's kind of interesting. We had this old surgeon in our town, and I mean, he was really old. He had trained at the Mayo Clinic back in the 20s. And I didn't really like the guy and didn't hang with him or anything. He was in the retirement phase when I came to town in 1980. And I walked into his room one day and he was doing a tonsillectomy. Now, he was a general surgeon, and most of the tonsillectomies in our town were done by the ENT specialist, who was really a young guy and really good, trained at Ohio State. But he was doing this, and I kind of walked in. I said, "Hey, Dr. Hyde, what you got there?" He says, "Oh, I'm doing a tonsillectomy. You ever seen one of these?" I said, "No, I've never seen a tonsillectomy." So he's got this kind of thing in the mouth, and he's looking back there in the back of the throat. And this little deal right here, the uvula, was kind of flopping down in the way. And he said, he kind of retracted out of the way, and it flopped back and flopped that, and he pushed it out of the way again. "Oh, hell, just a minute." He grabs it, cuts the damn uvula off right about there so that he could see the palatine tonsil back there. And I thought, did I just see that? But yeah, that crazy guy did that. Anyway, so that made it easier to see the pharyngeal tonsil. Normally, they have a special retractor now that they just put in there, and it kind of lifts the uvula. The palatine tonsil isn't really in the midline like it's illustrated here. It's really they're off to the sides. You can see your own palatine tonsils. If you open your mouth big enough and stick your tongue out far enough, you can see them on the wall on either side in these little crevices back there. And then they get this one up here. The interesting anatomy point to be made from this picture, which is really a nice picture, is that when this tonsil, when the adenoids get bigger, they block off this tube right here. And that tube is the
Pharyngeal.
nasopharyngeal, yeah, also called the auditory tube, also called the eustachian tube. Remember, it goes up and drains your middle ear. Remember that? Well, there's where it opens, in the nasopharynx. And that's why one of the reasons little kids get so many ear infections, because their tonsil here swells up a little bit, blocks that thing off, and then they can't drain their middle ear and they get ear infections. Part of the problem is also the fact that the auditory canal, the auditory tube in children is so short and small that it gets blocked off. But there it is, right there.
How does that, I had mine out, and I've never been able to go underwater since, because the water always goes it just goes right in my nose, and it didn't used to before. Even if I'm blowing out, I can only blow up for so long. Where does that kick in?
Well, I don't know, but obviously there's a big, huge connection here up into your nasal cavity. This is your whole nasal cavity up here, everything above your